Well, hello everybody. I would like to welcome you all in another part of CardioRisk Wave series regarding dyslipidemia and its management. Today we have a great faculty, either as a discussant or as speakers, and I would let the mic to Professor Atif Al-Bahri to introduce the first presentation. To Atif.
Thank you, Ashraf. I welcome everyone. And we have now a new wave for the IAVA. We have the first speaker will be Professor Ahmed Shawi Sarafi, Professor of Cardiology from Ain Shams University, and a very important topic of screening for familial hypercholesterolemia, which we want to concentrate on how to discover those affected in our population. Dr. Ahmed, please proceed.
Okay, thank you for the lovely introduction. Good evening, everybody. It's a pleasure to be in this continuous medical education by the IAVA and sponsored by Amgen. And actually, when talking about familial hypercholesterolemia, some of the patients I've seen really come to mind. This is an example. A 40-year-old male. He had a history of myocardial wall infarction on the inferior wall and had a drug-eluting stent done. He's dyslipidemic, of course, and he had a family history of coronary artery disease in the father at the age of 46. He also has recurrent chest pains and leg claudications. And if you look at his angiogram, definitely there is lesions all over the coronary tree. You can see the circumflex, you can see a borderline lesion in the LAD and the previously deployed stent in the RCA, and it was dilated. So this is really an important thing to take in consideration. A young patient with, multiple events, multiple chest pains, and this is really something that we see a lot in our community. If we look at the risk factors for atherosclerosis, at the top, for the odds ratio, definitely for myocardial infarction, elevation of the cholesterol is the most important or the most attributable as a risk factor. And if you look at the regression data coming from whether prospective cohort studies, randomized control trials, or even Mendelian randomization studies, the lower the LDL, the better the outcomes for the patients. This is not a J curve, this is a linear curve. There is no, increase in outcomes if we go very low with the LDL. It's actually different from hypertension and diabetes. LDL lower is much better. And if we look at the time course, not only if we go lower, but if we start earlier, if we start better, if we start more aggressively, we actually might really initiate stabilization of these plaques and help stop the progression, and thus decreasing the events like ischemic heart disease, cerebrovascular disease, and peripheral vascular disease. So this is really important. So the first question that comes into mind, is our patient a regular ACS patient? You might think, yeah, well, we see 40s and 30s and 50s every single day. Well, actually, we should really think about what we're thinking, because familial hypercholesterolemia can affect a lot of patients, a lot of people. Actually, it can increase mortality at the young age, even before the patients become in their 10s or 20s. This is very important. And actually, familial hypercholesterolemia is the most commonly inherited disorder. We used to think it was 1 in every 500 as data that's seen before. But actually, if you look at the newer data, it's the heterozygous is 1 in every 200 or 250. Actually, even more prevalent in those who get married from each other, like Ashkenazi Jews in South Africa. We get some from the Lebanese data, the 1 in every 67. So this is important. And the homozygous, in which there's a defect in both genes, actually, we thought it was 1 in a million. Actually, it can be 1 in 160,000. So it's not uncommon. It's the commonest inherited disorder. And the earlier it starts, especially with the homozygous, the mortality or the event rate can occur before even reaching the age of 10. Actually, on average, 12.5 years. The heterozygous hits later at 30s. This is in comparison to our normal population. Atherosclerosis probably hits at the age of 55 or plus. And how to diagnose is quite an important thing, because we're just saying this is a young patient, maybe he had some stress, maybe he's a smoker. Well, actually, there are three major ways of diagnosing familial hypercholesterolemia. There's the Simon-Broom, according to some clinical data and LDL levels. There's the MedPed, just total LDL levels, and the Dutch Clinic Lipid Network. So if we look quickly, the Simon-Broom looks at definite or possible hypercholesterolemia depending on the level of total cholesterol and LDL in the presence of xanthomas or a DNA-based mutation. And this is quite important. It's quite applicable. It's simple. It's very feasible. It's easy to use. But actually, it is not able to differentiate the different types of familial hypercholesterolemia. It cannot discriminate between familial hypercholesterolemia and others like secondary hypercholesterolemia or cytosterolemia. There's an overlook of a substantial proportion, and there's no understanding of the genotype-phenotype correlation. The MedPed is just, correlating the different levels of LDL to the age groups, and this is depending on the relative degree of your family relative. And this is just actually looking at just LDL and cholesterol. It does not take into consideration clinical characteristics. And there are various factors that influence the variation in total cholesterol. So again, not really holistically very accurate. But this is the most accurate, actually. It looks a little bit, what we can say, complex, but actually it's simple. You look at family history. This is the Dutch Lipid Clinic criteria, looking at family history, whether in your relatives, especially if patients have relatives with known LDL above the 95th percentile, and especially in those who are below the age of 18 and have a high LDL. The history with premature in males below the age of 55. Remember, our patient was 40-something, and women below the age of 60. Physical examination, LDL levels, and there's a scoring for the different LDL levels with a score of 8 for those with an LDL level above 325. And if you look also, finally, it's the DNA looking at the functional mutation, and if there is a functional mutation, there's 8. So how does it sum up? If you have a patient with 9 points or more, this is a definite FH. If it's 6 to 8, this is a probable, and the possible is that who gets 3 to 5. So the Dutch Lipid Clinic criteria actually is the most holistic, is the most accurate to really look for patients with familial hypercholesterolemia. So why screen? Why look at these patients? Because really, actually, abnormal lipid values and high lipid values are quite prevalent. And there is, as we've seen, the relationship between the elevation of LDL and atherosclerotic cardiovascular disease. And there is this negative relationship in which when you treat, there is a reduction of events. So this is very important. And because this has an autosomal dominant, sometimes, sharing to a lot of patients, it runs in families. You can really catch patients before they have an event, and this is an early intervention and important. Why is that? Again, familial hypercholesterolemia needs to be screened because the mortality rate of atherosclerosis and FH is hundreds of times those, especially those below the age of 40. And actually, in females, it can go up to 200 times the mortality rate in females without FH. And actually, untreated heterozygous, and this is the more simpler form or the less dangerous form, have a dramatic increase of premature atherosclerosis if not treated well. And also, we have a very inadequate identification. Maybe the only country with a really good amount of identification is Holland or the Netherlands, and this is because they did a full country screening, and this is really important to take into consideration. And if you look at data, actually the myocardial infarction rates in those with familial hypercholesterolemia, if they were treated with statins or not treated, actually those treated with statins do fare better, and they are actually closer to those who are normal individuals in the population. So it is an important health problem. Some may argue that there is no really study showing a positive effect on screening in below the age of 40. If you remember, most of the scores that we use are above the age of 40. So should we delay be above the age of 40 or not. Again, screening the whole population can be costly. Sometimes use of unnecessary medications in some situations. But actually, it's the acceptance of treatment, and it differs from country to country. We can say that in Europe, actually, they document the use of rosuvastatin at the age of 6 or more. In the United States, it's 8. Sometimes it's 10, according to other data seen from different studies. And we need a suitable test for screening, because the majority of FH children have no physical signs or symptoms. Hypercholesterolemia is asymptomatic. It should be an easy blood test, quick, easy, and expensive. And as we know, if we're going to look at genes, genetic testing is quite expensive. So the European Atherosclerosis Society say those children suspected of FH should be screened at the age of 5. In the United States, they can actually selective screening at the age of 2 in certain patients, but actually, if you look at the ACC/AHA, it's around 20. And then is it fasting or non-fasting? Usually, it's a fasting lipid panel. And if we detect these patients quicker, earlier, actually, the mortality and major adverse cardiac events are reduced significantly. And this is really important if you compare it to those diagnosed later. How to do it with a finger prick or venipuncture, the cost of testing, this is different from country to country. And the cost effectiveness actually will show a cost effectiveness, because actually treating these patients early or controlling these patients early reduces expensive cardiovascular events. And this is data seen around the world, actually in the Netherlands, followed by Norway. These are the best, countries that have screened for case finding. And we know we have data here from Egypt, which is quite low. And Professor Ashraf Reda is the head of this data. We are nowhere near the Netherlands or Norway. So if we screen early, we can effectively treat, and thus really reduce morbidities and mortalities like myocardial infarction, strokes, and death. And some thoughts we should take. Universal screening starting at the age of 5 or 10 should be continued. It's not just one thing done at one time in time. And we should be the primary goal that screening should be the best, and cascade screening in those with relatives having a premature coronary artery disease or cerebrovascular disease is important. And we should not look just at the age of 40, we should look beyond that in those with our earlier, especially in homozygous, because most of the patients don't live to 20 actually. And looking at the cascade screening, and this is very important, whether the cascade or reverse cascade at first and second degree relative. First degree is the most important, second degree comes as a secondary endpoint. And there is data also, even after acute coronary syndromes, that screening for familial hypercholesterolemia really reduces the occurrence of coronary events. And this is quite important also to reduce mortality. So instead of, just waiting for the lesion to increase and cause problems, we're trying to prevent them and prevent events thus. So what do the guidelines say? Actually, familial hypercholesterolemia is indicated as a very high or high risk category, whether the patient has an established cardiovascular disease, atherosclerotic, of course, or having just one major risk factor. And those without any major risk factors are considered high risk. So FH is not something to play around. And actually, in the European guidelines of 2019, they were, given a big shot in, talking about familial hypercholesterolemia. And those should be, treated aggressively with a 50% reduction in LDL, whether reaching 70 in the high risk or 55 in the very high risk. There is recommendation class 1 to use the Dutch clinic lipid criteria or the clinical criteria, and whenever possible, DNA analysis. Cascade screening is a class 1 indication. So actually, familial hypercholesterolemia is not something to really go ahead and, don't think. It's a very common disorder. And testing for FH in children, again, as I said previously in the lecture, it is from the age of 5 or even earlier. And this is class 1 if there is homozygous familial hypercholesterolemia is suspected. So to take home, LDL elevation is the cornerstone for the atherosclerotic process, increases mortality, cardiovascular events. And familial hypercholesterolemia is the commonest inherited disorder. It's more common than we used to think, especially the heterozygous. And I know there are so many genes implicated with the LDL receptor, the PCSK9, the apolipoprotein. And earlier diagnosis, especially in heterozygous and homozygous, and I'm talking about the age of 5, even earlier, if you have a suspected homozygous, may have a better prognosis. And we've seen this through several studies everywhere, all over the world. So screening and cascade screening of first degree and then second degree is extremely important to identify subjects at risk. And thank you.
Thank you very much, Dr. Ahmed.
Okay.
Ahmed. I don't know why they don't open my video. Ziad.
It was okay a while ago, a moment ago.
I don't know why is this stop with my video.
We will open it now, doctor.
Okay. Dr. Ahmed, we see here the importance of screening, as we see, and we need from the board of IADA, and here we have Professor Ahmed Bindari, who arranges a CRF. In order to collect our data, we need a digital, easier CRF placed on our website in order to place our data for the discovered cases and their families. And we hope that also that because most of us, we discovered some cases, and after that we neglected, or we are busy, or we are not able to introduce it correctly in a paper. So I asked Professor Ashraf if we can have this digital CRF immediately, and in order to have, because we have many cases are not introduced.
Well, thank you, Atif. Actually, this is easy, but I want to tell you that who is keen to record his case will record it whether online or on a paper. For example, you are recording most of your cases and send it to Bindari or send it to me, and it is registered. So
Yes.
we have to encourage registration of such cases, whether online or it's easy to be online. But we thought that it will be more difficult for the doctor to open the internet and then try to enter his data. Rather, it will be more easier to record in a small paper or fill the CRF in a small paper. Anyway, I want to ask Professor Shawqi about the social effect of familial hypercholesterolemia. For example, I had a patient, 2 young child, 2 and 4 years, with homozygous familial hypercholesterolemia. And you know what? Every one of the parent is keen to prove that he is not responsible for the familial hypercholesterolemia. Even they refuse to do lipid profile. So it has even a social effect. So screening is important, and here is the role of reverse screening, as you أشرت إليه. This is the definition of reverse screening. You discover the case and then go to do lipid profile for the parents, for the aunts, for the older brothers, and so on. So, do you think, Dr. Shawqi, that we are doing well in asking lipid profile for younger person in our clinic?
That's a very good question. And if you look at the chart I've shown of the world, and you published it, Professor Ashraf, you were part of it, it's only the Netherlands that have shown a good amount of screening. The whole rest of the world, including the United States, the United Kingdom, they're not doing so well. Maybe we are, part of it is physician inertia. We're not insisting more and more. And sometimes, yes, like you said, the parents think it's not me, it's not. No, we're trying to look if you have a gene or something or a lipid profile which is high, because we don't want you to die from, a coronary heart disease or a cerebral vascular stroke. It's maybe the way we're presenting to them the question. But definitely, yes, screening, cascade screening or reverse cascade screening is quite important, and we should insist on it more.
Thank you, Professor Ahmed, for this, as usual, very elegant presentation, very coverable, and to the point presentation. I'm still thinking about what Professor Ashraf is mentioning about the screening, and I think one of the important tracks to screen the population and to reduce the cost for treating those patients with familial hyperlipidemia is the doing the screening during the admission to the job. During admission to the job, if we do a sample for lipid profile, I think this will be very effective in screening for familial hyperlipidemia, and also it will be very effective for reducing the cost for those patients who did not know that they are dyslipidemic with high LDL, and they will be doing PCIs, cabbage, hospitalizations. I think it is very important to mention.
I agree. Okay.
اتفضل يا احمد، اتفضل يا احمد.
No, I agree totally. There should be some sort of governmental way, and this is what happened in the Netherlands. Actually, they screened the whole population, and that's how they got their 70-plus screening capability. So I agree with Professor Said. It's a very important thing to do.
Anyway, I think we should do a lot regarding screening, at least with simple lipid profile. But as Dr. Shawki said, it's important to be this screening belonging to a central part capable of dealing with the data, because you may do a lipid profile for an employee, and then who will see this data, which is الحكومة ولا وزارة الشؤون الاجتماعية ولا وزارة العمل. It's very important to collect this data centrally to those capable of analyzing that data. The second thing is that it is something have a legal issue. If it has some high elevation in cholesterol and you diagnose him as familial hypercholesterolemia, it will be very difficult for the employment processes to be taken over. Any other comment or questions from?
Yes, I'd like to direct my question to Professor Ahmed Bindari. How much the estimate of our cases now? Do you have an idea?
Thank you, Professor Atif, for this question. We have not yet screened the general public for the prevalence of familial hypercholesterolemia. However, we did an intelligent analysis coming from the CardioRisk project, which studied patients with acute coronary syndrome across Egypt. And we came to the conclusion that, and I'd like Dr. Ashraf Rida to correct me if I forget something, that according to the Dutch Lipid Network criteria, the prevalence of possible FH among Egyptian patients with acute coronary syndrome was about 14 to 15%.
Yeah, 17%.
Yeah. And when you come up to the more higher categories, such as probable and definite, we estimated that the prevalence is about 0.5 or 1%. Is this correct, Dr. Ashraf?
Yeah, sure. So as you said, around 17% of our patients admitted with acute coronary syndrome are possible or definite.
At least possible.
At least
and
possible.
if calculated by person, how much?
Per person?
How much? 17%.
17% of sample of patients of acute coronary syndrome all over Egypt.
3,224 patients.
2,000.
3,224. 3,224.
Okay.
اسمح لي يا دكتور اشرف، هو actually there is an international meta-analysis about the retrospective analysis of our patients of very high-risk patients, about 25–26% of all our patients in acute coronary syndromes, it is familial hypercortisolemia. Actually, it's about a quarter of our patients maybe have a familial hypercholesterolemia. I think it is very important to search about and to screening, as Professor Ahmed Shawqi said elegantly. The screening is very important to those patients and the relatives
Okay. If there is no other questions, I think Professor Ala Atman can introduce the second presentation.
I'd like to introduce an eminent professor and the eminent cardiologist and very smart, intelligent speaker, Professor Dr. Ahmed Dindari from Banha University, about the lipoprotein A. Actually, it is a forgotten lipid, very important risk factor, and I think Ahmed will give the light to shape this very important topic. Go ahead, Ahmed.
Thank you, Professor Ala, for this lovely introduction. I'd like first to check that the image and the voice are streaming clearly.
Yes, it's okay.
Okay, I'd like all my viewers to follow this moving laser pointer because I'll use it frequently during the presentation. All of us know that what we call lipoprotein little a is risk factor for the future incident atherosclerotic cardiovascular disease and events. It's also a risk factor for aortic valvular stenosis. During the upcoming minutes, we will shed the light on the structure, the pathophysiological role of lipoprotein little a in induction of atherothrombosis, and then we will see the link between lipoprotein little a and atherosclerosis. Finally, we will try to dissect the different treatment options we have now in treating this lipoprotein little a excess, which I congratulate the selector of the topic. It's actually a forgotten lipid. If we ask a very basic question, what's the structure of lipoprotein little a? Actually, and in simple terms, lipoprotein little a is an LDL molecule. So what's the difference? The difference is that we had a glycoprotein called apolipoprotein A, which is covalently bound to the famous ApoP100 by a disulfide bond. The chain of apolipoprotein A contain 5 cysteine-rich domains. These domains are called kringles, and the kringle number 4 is quite similar to the fibrin binding site of plasminogen, and all of us know that plasminogen is a very important plasma protein involved in fibrinolysis. And this takes us to the mechanisms by which lipoprotein little a could promote atherothrombosis. It goes without saying that lipoprotein little a, through the similarity I just mentioned between the kringle 4 and the fibrin binding site of plasminogen, could interfere with the natural defense mechanism of fibrinolysis. Moreover, this lipoprotein A is in and of itself a lipoprotein, so it can promote the formation of foam cells. Moreover, it can bind to the endothelium, inducing endothelial dysfunction, and also enhancing the expression of what we call intercellular adhesion molecule, or ICAM1, and finally, through the structural change in the LDL by the apolipoprotein A, this makes LDL more susceptible for the oxidative modification, and this enhances the process of atherosclerosis. So these are the main mechanisms through which lipoprotein little a could promote atherothrombosis. But let's dive deeply into the genetics. And let's say the first word is that serum lipoprotein little a levels are genetically determined. This is written in your genes. It's written that you as a person will have a high lipoprotein little a, or me as a person will have a low lipoprotein little a. The environmental controlling factors here is not, or let's say are not very evident, like the LDL, the triglycerides, and so on. And one of the very important polymorphisms in the genes encoding the apolipoprotein A, which is the apolipoprotein present in the lipoprotein little a, is the Kringle 4. You remember the Kringle 4 I just mentioned a few minutes ago? Kringle 4 type 2 size polymorphism. Please remember this polymorphism, Kringle 4 type 2 size polymorphism. But why? Because up to 60% of the population variation in the levels of lipoprotein little a is related and closely determined by this polymorphism. I'll say it again, Kringle 4 type 2 size polymorphism. This is the polymorphism responsible for the population variation in the levels of lipoprotein little a. And always keep in mind that lipoprotein little a levels are genetically determined. And we have a very strong inverse relationship between the size of the apolipoprotein A isoforms and the lipoprotein little a concentrations. When you have a larger isoform in terms of size of the apolipoprotein A, you will have smaller concentrations of the lipoprotein little a itself. Please here, in order not to get confused, don't mix between lipoprotein little a and apolipoprotein A. Apolipoprotein A is just the apolipoprotein contained within the particle of lipoprotein little a. And finally, if we look by a bird look to the general population, we will find that the distribution of serum lipoprotein little a concentrations is skewed towards lower values among most racial and ethnic groups. However, when you look to some ethnic groups such as Black Americans, Africans, and Asian Indians, you will see a more normal distribution towards a higher level. So, to conclude, it's not only the fact that lipoprotein little a is genetically determined, but also it differs significantly between different racial and ethnic groups. And to the difficult point, and this is the measurement. Why do we most of the time don't see lipoprotein little a in our lab values? This is because the measurement of lipoprotein little a is quite difficult. And we have for measurement two methods. The first method estimates the lipoprotein little a what we call molar concentration by using ELISA. And this has been found to better predict the future incidence of atherosclerotic CVD compared to the other methods. The other methods are the turbidity method using what we call nephelometry and measurement of the lipoprotein little a cholesterol content, not the lipoprotein little a particle itself. And we should express our measurements into units. And because we have two major methods of measuring lipoprotein little a, we have two major units. The first unit, which expresses the mass units, is called the milligram per deciliter. And the other unit, which expresses the molar concentration, is called nanomole per liter. And due to the fact that these are two completely different methods for measuring the lipoprotein little a, conversion from the milligram per deciliter to nanomole per liter is not very accurate, despite the fact that the calculators are there. Do you remember the kangaroo? The kangaroo contains its child within a bag in its abdomen. And this is exactly what happens when you are measuring the low-density lipoprotein cholesterol. Low-density lipoprotein cholesterol includes the cholesterol content of lipoprotein little a. And this is simply because lipoprotein little a is actually an LDL, but modified LDL. And finally, remember, I have said just 1 minute ago that lipoprotein little a is genetically determined. And these levels will usually become stable in healthy individuals over time. If you were born with low level of lipoprotein little a, mostly it will remain normal across your life and vice versa. I hope this is clear. But please keep these 4 points in mind before we go deeply. Number 1, when I say lipoprotein little a, I'm not here speaking about the lipoprotein little a cholesterol content. This is the thing, and this is another thing. Number 2, if we would like to measure the cholesterol content of lipoprotein little a directly or specifically, this could be done on the isolated lipoprotein little a particles using LBA4 magnetic beads directed specifically against the apolipoprotein A, which is the apoprotein present in the lipoprotein little a. And since, as I have just mentioned, substantial amount of LDL cholesterol is actually carried as lipoprotein little a cholesterol, some experts are recommending to measure what we call the corrected LDL cholesterol. So we can say that the corrected LDL cholesterol is the pure cholesterol carried by the LDL, excluding the cholesterol content of lipoprotein little a. So it makes full sense that we can measure it by equation, one of 2 methods. First, you can obtain the corrected LDL cholesterol by subtracting the direct cholesterol of lipoprotein little a. We have estimated it in the step number 2 from the laboratory LDL cholesterol that came from the lab. But we cannot do the direct lipoprotein little a by this sophisticated technique, the LBA4 magnetic beads directed against blah, blah, blah. We have the Dahlin formula. The Dahlin formula illustrates that or teaches us that you can obtain the corrected LDL cholesterol by subtracting the lipoprotein little a mass in milligram per deciliter multiplied by 0.3. This obtains roughly the direct lipoprotein little a cholesterol from the laboratory informed LDL cholesterol. The one important thing, or the single most important point I'd like you all to keep in mind is that the cholesterol content of lipoprotein little a is a completely different thing and a completely different entity than the lipoprotein little a particle itself. And now to the difficult question. Do we have an evidence behind the heightened cardiovascular risk in patients with lipoprotein little a excess? And actually, yes, we do have this evidence. Back in 2009, in the JAMA, we see this important cohort study which divided patients according to their lipoprotein little a level into percentiles. And it was found that those patients in the highest percentile, more than 99th percentile, had the highest adjustable hazard ratio for the occurrence of the future myocardial infarction. And this is not a chance. The same year, the New England Journal of Medicine published what we call the BRUCARDIS cohort study, in which individuals containing more than one variant allele for the gene encoding the apolipoprotein little a were found to have a significantly higher level of the lipoprotein little a particle itself and a significantly higher odds ratio for developing coronary heart disease in the future. And I'd like to draw your attention to this recent meta-analysis published in Lancet, which contains the data, the individual patient level data from more than 29 patients from 7 placebo-controlled statin trials. As you can see, it was found that the baseline level of lipoprotein little a and even the on-statin level of lipoprotein little a is predictive for the occurrence of incident cardiovascular disease. What I'd like to say is that whether you are a naive person or whether you are statin treated, the excess lipoprotein little a will predispose to a high probability of future cardiovascular disease. And the cutoff value for the baseline level was 30 milligram per deciliter for lipoprotein little a, and on statin 50 milligram per deciliter for lipoprotein little a. So statins do not favorably affect the relation between excess lipoprotein little a and heightened risk for future cardiovascular disease. And I'll come to this now. And even the recent trials which randomized patients between receiving PCSK9 inhibitors and placebo, such as the Fourier trial, which randomized the staple atherosclerotic cardiovascular disease patients between receiving evolocumab and placebo, showed the same pattern. If you look into the data, you will find that in the Fourier trial, those patients who had a baseline lipoprotein little a below the median enjoyed a lesser benefit compared to those patients who had lipoprotein little a above the median. What I'd like to say is that if your baseline lipoprotein little a is high, or let's say above the median, or above 120 nanomole per liter, you will get a higher benefit from PCSK9 inhibitors, despite the fact that your future events may be high. And not only cardiovascular disease and cardiovascular mortality. Let's broaden the term. The relation between lipoprotein little a and all-cause mortality is there. Look with me to this important observational study that was published in the European Heart Journal in 2019. It was found that excess lipoprotein little a above 98 milligram per deciliter, especially when coming through the famous mutation I just mentioned 5 minutes ago, the Kringle4 type 2 mutations, which again is responsible for more than 60% of the population variation in the level of lipoprotein little a. It was associated of or with 10%. The hazard ratio here is 1.1, 10% increased risk for future all-cause mortality. And this is very curious. And I'd like to highlight the fact that the prevalence of lipoprotein little a excess was found to be higher in patients with heterozygous familial hypercholesterolemia, according to this important paper published in JACC in 2020. This was a paper done on more than 40,000 patients with heterozygous familial hypercholesterolemia. It was found that the prevalence of elevated lipoprotein little a among those patients is high. And this paper came to 2 very important conclusions. Number 1, patients who were found to have a high lipoprotein little a level among those patients with heterozygous familial hypercholesterolemia, those patients were found to have a single risk allele. And due to the fact that the clinical presentation of both conditions is quite similar, and due to the fact that statins do not decrease the level of lipoprotein little a, and even, and sit down for this, statins may increase the level of lipoprotein little a, those patients could come easily to the clinical attention. Imagine a patient with LDL baseline 200, and he or she was given high dose statins, and due to the fact that statins do not lower lipoprotein little a, and due to the fact that lipoprotein little a is swallowed within the LDL pool, those patients will come easily to your clinical attention in the form of non-responsive LDL to statins. But in reality, those patients are having excess lipoprotein little a, not truly familial hypercholesterolemia. I hope you got the point. And so it was not surprising that the guidelines are endorsing the great importance of lipoprotein little a. Look with me to these recommendations from the 2019 European Guidelines for Cholesterol Management. You will note that the guidelines gave class 2A recommendations that lipoprotein little a should be measured, look to the word, at least once in life, مرة في العمر, to identify those with very high levels, and the guidelines put the cutoff value of more than 180 milligram per deciliter, and the guidelines say that those patients have a lifetime risk similar to those patients with heterozygous familial hypercholesterolemia. And now to the last station, and actually a very difficult question. How could we manage the excess lipoprotein little a or lipoprotein little a excess? I'd like to start by 4 bad news. The first bad news is that there is limited evidence, very limited evidence, indicating that lowering lipoprotein little a will translate surely into a better atherosclerotic cardiovascular disease risk. And what increases the problem is that, well, as I just mentioned few minutes ago, statins increase lipoprotein little a level. I'll say it again. Statins increase lipoprotein little a level. However, the impact of this increase is not known on the cardiovascular events. And even ezetimibe, forget about it. It doesn't lower the lipoprotein little a. And the use of advanced therapies, including the PCSK9-based therapy, has not been tested in prospectively randomized clinical trials. All data we have about the effects of PCSK9-based therapy is coming from post-hoc or pre-specified secondary analyses from the randomized trials, which were not powered to detect the difference in lipoprotein little a with treatment. But all in all, I'd like to draw your attention for this pre-specified analysis coming from the Odyssey outcomes trial, which randomized patients atherosclerotic post-acute coronary syndrome between receiving alirocumab and placebo. And if you look into the figures, you will note that the benefit of alirocumab is dependent on the absolute reduction of lipoprotein little a, irrespective to the corrected LDL cholesterol and the corrected non-HDL cholesterol. The high bar for above, this high bar, this high bar, this high bar, and this indicates the magnitude of reduction in lipoprotein little a. As you can see, when you obtain more reduction in the lipoprotein little a, you will obtain more reduction in the major adverse cardiovascular events. And if we would like to translate into numbers, for every 5 milligram per deciliter reduction in the level of lipoprotein little a using this PCSK9 inhibitor alirocumab, you can obtain a corresponding significant 15% relative risk reduction in the future incidence of major adverse cardiovascular events. And we should not forget this molecule, the niacin, despite the fact that it's not commonly used nowadays due to the very, very silly side effects. It has been shown in this randomized trial, and this is the only randomized trial we do have, that niacin reduces lipoprotein little a significantly compared to gemcitabine. And if one questions about the utility of lipoprotein apheresis in reduction of lipoprotein little a, I will say yes, we have data. Look with me to the BRU-A-LIFE study group, which was an observational prospective multi-center study evaluating lipoprotein apheresis efficacy in reduction of lipoprotein little a. It was found that lipoprotein apheresis could cause temporary reduction in the level of lipoprotein little a by as much as 75%. And this potentially could translate into better MACE and adverse cardiovascular events. Look with me to the bar here, comparing the 2 years before to the 2 years after using lipoprotein apheresis for treating excess lipoprotein little a. And mentioning lipoprotein apheresis, I'd like to highlight this randomized clinical trial, which was recently published in the European Heart Journal. This was a small trial but randomized, done on just 20 patients with refractory angina, who were randomized between receiving weekly apheresis for 3 months or a sham procedure. And sit down for this, the baseline lipoprotein little a excess in those patients was 500 milligram per deciliter. And despite this very high level, apheresis resulted in significant improvement in myocardial perfusion reserve, even and in the quality of life in those patients. So the potential for lipoprotein apheresis for reducing lipoprotein little a and hopefully reducing the future adverse cardiovascular events is there. Finally, about 2 years ago, the New England Journal of Medicine published what we call the AXIA-APO-A study. And this was a randomized, double-blind, placebo-controlled dose-ranging trial evaluating different doses of what we call the antisense oligonucleotide, pelacarsen, in the reduction of lipoprotein little a. And it was found that it could reduce lipoprotein little a by this dose, 20 milligram every week, by as much as down to 80%. And one here may come and say, Ahmed, this reduction is not exactly in lipoprotein little a. You told us, or you mentioned, that lipoprotein little a is swallowed within the LDL pool. So the pelacarsen, through reduction of LDL, could, by the way, reduce the lipoprotein little a. And I'll respond by this very recent data published 2 months ago in the JACC, in which investigators dissected the LDL into the corrected LDL I just mentioned a few minutes ago and the cholesterol content exclusively carried by lipoprotein little a. And as you can see, at the end of treatment by pelacarsen, the reduction or the relative reduction in the level of the cholesterol purely carried by lipoprotein little a was 67% compared to only 11% in the effect of the pelacarsen on the cholesterol of the LDL or the corrected LDL cholesterol. So the main effect of pelacarsen, which is an oligonucleotide, is mainly on the cholesterol of the lipoprotein little a specifically, not on the LDL pool as general. My final take-home messages for the sake of time is that lipoprotein little a is a causal independent risk factor for the occurrence of atherosclerotic CVD. Number 2 is that laboratory measurement of lipoprotein little a is not easy and even is not standardized. Number 3, atherosclerotic CVD risk increases as clinically relevant as lipoprotein little a concentrations exceed 30 to 50 milligram per deciliter, and especially as the guidelines have said when the level exceeds 180 milligram per deciliter. There is no broad agreement when to screen for lipoprotein little a excess, mentioning the screening as Professor Shawi said, so we prefer targeted screening. We have no clinical trials that have adequately tested the hypothesis that reducing lipoprotein little a could and should translate into better outcomes. The initial approach recommended is to reduce the risk through the reduction in the LDL, and advanced therapies could be tried if you have tried all options and your LDL targets is still or are still not goal. I'm grateful that you listened. Thank you. This was me signing off, and goodbye.
Thank you, Bindari. Actually, elegant presentation. And I'm happy you highlight the importance of difficulty in testing lipoprotein little a, and on highlighting what parameter are we testing. Because most of the randomized trial you mentioned, and even the Odyssey trial, use the lipoprotein little a cholesterol content, lipoprotein little a cholesterol, as a reflection of the lipoprotein little a, which may not a very accurate assessment. It gives an idea, but the best to diagnose genetically elevated lipoprotein little a is to test specifically for the lipoprotein little a itself. And this is very difficult subjects, because they are not measuring it in milligram per deciliter like cholesterol. They use even these Kringel's repeats in assessment and the molecular weight of ApoA itself. So this is very important, and accordingly, unfortunately, we don't have any drug that is proven to reduce the lipoprotein little a, except, as you mentioned, some effect of niacin, some effect of PCSK9 inhibitors. Any questions or comments from the faculty?
Ashraf, please. Yes, I'd like to thank you, Ahmed Bindari, for your intelligence and for your always prepared presentations. In a recent paper published in the European Atherosclerosis Society in the 25th of May this year, Catabano and Elena Ormastrone from Italy, from Milano, they published a paper, and they present this paper in the conference this year, and they stated that the lipoprotein A does not have significantly any arterial or venous prothrombotic effects. And we know from 3-4 years ago that it is atherothrombotic and the prothrombotic. So how they make this paper, and now we are away from the prothrombotic effect of the lipoprotein A. It make some disturbance and some confusion because all the papers they published before, there is evidence of the prothrombotic effect of lipoprotein. How do you have any explanation, or even my colleagues have any explanation? Because I read it 2-3 times, and I found it is a negative study. There is no effect on prothrombosis, and this is from the lab of Catabano in Milano.
I think, of course, one study should not change our consensus about the relation between this molecule and the excess cardiovascular disease. However, the major difference, I have not read the paper yet, but it seems that the method of measuring lipoprotein little a could have a rule. All other studies are measuring the cholesterol content of lipoprotein little a, which is actually carried within the LDL pool. However, they may have measured the molar concentration of lipoprotein little a particles by ELISA expressed by nanomole per liter. And who knows, maybe with repeated studies such as this, we could have cumulative data about the actual relation between lipoprotein little a excess and atherosclerotic cardiovascular disease.
Dr. Ashraf,
I think we have to differentiate between what Catabano wants to say. He wants to prove that in addition to the atherosclerotic effects of high lipoprotein little a, the idea that it have another prothrombotic effect due to structure similarity of plasminogen is valid or not. So this negative study does not mean that lipoprotein little a is not related to atherosclerotic cardiovascular disease. We have important, strong evidence from Mendelian randomization studies, from genetic studies, that genetically high lipoprotein little a is related to atherosclerotic cardiovascular disease. And I encourage you to try to test for lipoprotein little a. If you find a 42 years gentleman like the one I just saw yesterday, he's playing tennis, is okay, but he feels some discomfort all the time. And one of his friends asked him to do CT scan, CT angio for that. So he do CT angio and he found a very tight LDL lesions. I was very astonished because his lipid profile is completely normal. So I think this is an example of when to try your effort to do lipoprotein little a test for him.
Another point, Professor Ashraf, I'd like to highlight, if we are speaking about when to screen for lipoprotein little a, if you gave a patient with high LDL statins and you are increasing the dose of statins and the response to statin therapy is not that good. For example, I mentioned a patient who had a baseline LDL of 200 and you gave him, for example, rosuvastatin 20 or even 40, and you have obtained just a 20% reduction in the LDL. This is not usual. You should obtain at least 50% reduction. Test this patient for lipoprotein little a, because the statins do not decrease the lipoprotein little a, even they may sometimes increase it. So patients with suboptimal response to statin therapy are candidates also for screening.
Those resistant to statin therapy are probably due to problem in the LDL receptors. Many of them are heterozygous familial hypercholesterolemia with typical LDL cholesterol high. Persistently elevated LDL cholesterol despite treatment does not mean that they are lipoprotein little a, but it is one of the causes. Explanation you may search for. If there is no other comments, I think Professor Tamer with us. Tamer Mustafa?
Would I ask you something?
Sure, yes.
And Dr. Ahmed, thank you, Dr. Ahmed, informative and comprehensive as usual.
Thank you.
How many times you asked for lipoprotein little a? I may have a consensus from here because the guideline says once upon a time in your life you should have it. Is it some clinical scenarios, if we came to the ground, some clinical scenarios like those with recurrent polyvascular disease or recurrent need for stenting, as Dr. Ahmed said, the example he gave, what do you think at the ground, on the ground?
Do you want a friend answer?
Yeah.
I have ordered it once up till now for one of my patients.
That's
I know this is disappointing answer, but this is the reality, at least to me.
Yes.
But this is real for all of us, and you know why? Because there is no a valid test in Egypt. I don't know in Egypt who are validly test, and this is a problem all over the world, not only in Egypt, to test accurately genetically for high lipoprotein little a.
Yes.
Okay. Tamer with us. Alaa, you want to say something?
I think thank you Ahmed. It's very elegant as usual.
Thank you, Professor Alaa.
Very informative and very concise. But lastly, I want to addressing something. There is a residual cardiovascular risk still beyond LDL. So statin is not the only tool that we have, and we have to think about another combination therapy. And I think the guideline addressing this message very elegantly. And the combination is the first now to combine therapy to target the atherosclerotic cardiovascular disease, because you have a very slippery components of residual cardiovascular disease risk. So I think the lipoprotein, one of the important players, but as Professor Ashraf Reda said, it is very difficult to measure, as you mentioned also, but they have a bad player here, besides a non-HDL, besides a chylomicron, besides many bad guys. So I think, thank you very much. And I think it's very important, lipoprotein A, to be measured once a time, as the guideline mentioned.
Okay, you can share screen, Yasser, and if Tamer is with us, he can present this presentation.
Now we are honored to start with Professor Yasser Hussein. His presentation will be about the plaque aggression, and we will enjoy to listen to him. To Yasser.
Thank you. Is it shared now or not?
Not yet.
Not yet.
Okay.
And I think this is another important field, the plaque regression, because nowadays we are hearing the news from here and there that with very low LDL cholesterol, you may have some regression. And I think we need to know what is the current situations. Could we achieve this dream, actually, Professor Yasser?
Thank you, Professor Tamer. Thank you, Professor Ashraf, and all the faculty for the invitation, kind invitation. I think my slides and my voice are both clear.
Yeah, clear.
Yes.
Okay. This is the title I have been given, but allow me to dig a little bit in the plaque itself before going to the lowering strategies. I adore this slide because it's 2 centuries ago, and it is valid for life. Longevity is a vascular question. Over the last 3 decades, there have been substantial improvements in treatment aimed in cardiovascular outcome events to reduce it. And as these treatments have been developed, there have been parallel improvement in coronary imaging modality that can assess plaque volumes and composition, whether invasive or non-invasive technique is there. Please be sure that plaque progression precedes cardiovascular events. And therefore, many studies have longitudinally assessed change in plaque characteristics in response to treatment, aiming to demonstrate plaque regression and improvement in high-risk features. الحقيقة التحدي اللي عندنا كلنا اني مش بس اعرف البلاك مين بينزل الاثيروما فوليوم زي ما هنشوف، بقدر ما ان التشالنج اللي عند العالم كله في الاريا دي how to bring this results that may come from lipid lowering and reduction of atheroma volume into cardiovascular outcome, morbidity and mortality. It's a great challenge. What is a vascular plaque? I know all the attendees are professors. I put this slide or this animation just for clarification if any junior is there. But I think it's important for all of us to be reminded with it every now and then. Here is the LDL particles, and I don't say cholesterol, LDL particles, and most of time when it is small and dense, it hits the endothelium, bringing endothelial injury. Then the infiltrating monocytes with conformation changes to become macrophage to engulf the cholesterol to make foam pills, then fatty streaks. Then one of the protective measures that the cells try to do is the proliferation of the smooth muscle cell and its migration to the subendothelial area. The plaque comes more and more evident, and fibrin deposition to make the cap, which is one of the surrogate markers that we will discuss, trying to make it more thick. Necrosis happens, necrotic tissue, and then the proteolytic enzymes bringing the crack that happens or occurs in the endothelial wall, and the cascade of the thrombosis starts. If you have a sagittal section, we will see more and more contributors as regard the plaque itself. Leukocyte microparticles, interleukin-6 signaling, mitochondrial DNA damage, thin fibrous cap, entrance of some of the RBCs, the free hemoglobin would increase the oxidative stress, macrophages, as I have just elaborated in a while, the blood flow and the shear stress that may induce inflammatory process more and more for the plaque, and one of the claim that antihypertensives may decrease the atheroma volume, you will see, and the HDL importance as function and the particle number, and how it would affect the plaque burden with CETP pathway. This slide was there with the Professor Ahmed Shawqi as regard the LDL as a cause for atherosclerosis. This was in Mendelian randomization studies, in prospective cohort studies, and in randomized control trials. No doubt is there now that LDL is the main cause of atherosclerosis, and it has a linear relation with coronary artery disease, of course. But when you put the LDL levels through the life journey, and the LDL increases if the patient susceptible to, increases with polygenic hypercholesterolemia, and increases much more with familial hypercholesterolemia. As a mirror in the upper of the slide is the progression of the plaque accompanying the LDL progression from fatty streak to complex plaque. And if you see here, if you intervene at the fatty streak era or proper time, there is greater relative risk reduction for plaque resolution. But if you went into the complex plaque, there is a less relative risk reduction with plaque not resolution stabilization. So they are accompanying each other. And this famous slide, important slide, shows us that by time when the plaque increases by lifetime, we can attenuate the LDL by initiating statin early in those with familial hypercholesterolemia to flatten the curve as much as we can, and also for those with LDL high, etc. So the plaque is being there all the time with the journey of the LDL. And if we wrote some diaries for the plaque progression precedes the cardiovascular events, as we said. But improvements in coronary imaging modalities allow direct assessment of plaque modification. And the third point is very important. If outcome data linking plaque regression to reduce cardiovascular events emerge, لو حصل ان بقى في link بين البلاك regression والreduction في cardiovascular events, that would be awesome. Monitoring the response of coronary plaque treatment may ultimately having a surrogate marker like risk scores and lipoprotein levels. يعني احنا معتمدين في البرايمري على الريسك سكورز للبوبوليشن، معتمدين في السكندري على اللايبوبروتينز. حقيقه احنا بنطمح ان البلاك ريجريشن لو قدرنا by further studies than till now no clear study linked both together, the plaque reduction and the cardiovascular events, this would be great. The vulnerable plaque or the high risk vulnerable plaque, mainly two issues: high lipid content and thin cap. Simply, of course, a lot of factors are being there, but there are two main categories: high lipid content and thin cap. This is a plaque definition, and it is very important to know that type 1, we have type 1, type 2 till type 6 plaque. Initial lesion just showing isolated macrophage foam cells. Type 2 fatty streak. Type 3 intermediate lesion. The fatty streak comes more and more evident, plus more small extracellular lipid pool. Type 4 atheroma lesion. More and more announcement of the plaque. Type 5, which is called fibroatheroma lesion, lipid core and fibrotic layer, or multiple lipid cores and fibrotic layer, or mainly calcific or mainly fibrotic. All options are there, but it is so crowded a plaque, it's not like type 1 or type 2. And the most catastrophic one, of course, is the complicated one. When you have a complicated lesion, complicated plaque, surface defect, of course, as regard the cap, hematoma, hemorrhage, and thrombus cascade that happens. These are the main four aspects that coronary computed angiography for coronary arteries may delineate. First, there is positive remodeling, and the positive remodeling increased outer vessel diameter to maintain lumen, زي ما كلنا عارفين, and the positive remodeling index is more than 1.1. يعني بشوف المكان اللي فيه البوزيتيف ريموديلنج بشوف الادجيسنت فيسل، لو هو اكتر من 1.1 يبقى انا عندي لسه positive remodeling to allow and maintain the lumen diameter as it is. The napkin ring sign, low attenuation area, abutting lumen surrounded by high attenuation ring. Spotty calcium might be there. And one of the most important items that we judge the plaque with it is the low attenuation plaque. This is revealed by CT equivalent of lipid-rich component. عندنا الهانسفيلد يونت ده المفروض بأقل من 30، ده بيقول لنا بالحسبة بتاعة السي تي إن عندي هنا low attenuation plaque, thus I have some sort of lipid content. Don't look to this slide. I only like to drag your attention for this column. What are the factors and the conditions associated with increased risk of acute coronary events as regards the plaque characteristics? You should see or go for the plaque burden, lumen encroachment, as I have just elaborated, lesion location, is it ostial or bifurcational, plaque composition, plaque biology, plaque configuration, remodeling, and endothelial destruction. Here are the difference between the most used for modalities in imaging. I think this one is more clear. برضو الحقيقه هي السلايد بيزي، انا مش عاوز نروح فيها الا الحقيقه للفيتشرز اللي تقول لنا. طبعا احنا عندنا البنتريشن اقل بالنسبه للاو سي تي، لكن الكاب هتكون اوضح معاه، كل حاجه ليها وذ واجينست. لكن الفيتشرز اوف هاي ريسك بلاك الحقيقه انا حطيت عليها كلها. As regard the CT, you may see the eccentric pattern, outward remodeling, low attenuation plaque as I have just mentioned, spotty calcification and napkin ring sign. As regard the IVUS, of course, eccentric pattern is of value, outward remodeling, large plaque burden, large lipid core or the carotid core, and spotty calcification. Here, with radiofrequency or the virtual histology, we see the plaque composition, fibrous, fibrofatty, necrotic core, calcification, etc. In OCT, we are aiming to see mainly the thin fibrous cap, macrophage infiltration, new vascularization, and thus, for these reasons, OCT is of great value in judging the proper alignment apposition of the stent deposition. These are the imaging assessment of plaque regression before and after as a baseline and follow-up. In the most famous study for each one, in IVUS, the Japan Acute Coronary Syndrome ACS in 2009 shows the baseline here and the follow-up, the atheroma volume. The virtual histology IVUS here is showing the regression of the atheroma. The OCT points at the fibrous cap, and the coronary computed tomography angiography is the paradigm study, which shows the criteria I have just mentioned for the CT. Don't forget that we are dealing with a patient, not with a plaque. We are dealing with a plaque in a patient. So don't forget the vulnerable patient, and the vulnerable patient, a cornerstone in his scenario is the vulnerable plaque. Let's come to the core of the presentation, plaque regression strategies. First, we have non-pharmacologic: exercise, dietary and lifestyle, smoking cessation, alcohol abstinence. Unfortunately, no significant contribution for any of those in plaque volume regression. So let's jump to the pharmacologic. We have a lot of molecules and the classes that have been studied. Of course, statins, ezetimibe, PCSK9 inhibitor, and now the PCSK9 targeted therapy, icosapentaenoic acid, CETPI, lipoprotein little a, and triglycerides lowering agents. Antihypertensive agents are there studied for the plaque regression. Colchicine also is there. Anticoagulants have been studied. Oral hypoglycemic agents and other like silestazole, garlic, etc., extracts, and etc. Let's go for the main items that have been studied and share in the plaque regression. Let's go first for colchicine. Colchicine, in an open label, non-randomized recent trial using coronary CT to judge the results, post or recent acute coronary syndrome, patient with optimal medical therapy plus placebo, or patient with optimal medical therapy plus colchicine, and to see the results. The results showed significant reduction in low attenuation plaque volume and non-calcified plaque volume, but reduction in total atheroma volume was similar in both groups. Let's have another item. Ezetimibe. Ezetimibe in a lot of studies showed significant plaque regression, and those are the main trials that are contributing in the results of ezetimibe are put there. What about the icosapent ethyl? Data are mixed, conflicting. Cherry study demonstrating greater regression over 6 months among patients taking EPA, whereas 2 other randomized control trials, one using IVUS and one using CT, showed no significance. The evaporate trial, it's a coronary CT angiography trial, showed reduced low attenuation plaque, fibrofatty volume, and fibrous volume, and it was a positive trial. So there are conflicting data as regard the EPA. Lipoprotein(a) and triglyceride lowering agents, and I think Dr. Ahmed Bendari covered most of the data as regard lipoprotein(a), but I will take it from my point of view or my scope. Niacin showed no plaque regression. Also, PCSK9 inhibitor showed 25 reduction in lipoprotein(a), but also with benefits seen on plaque volume. Triglycerides lowering agents, all the agents like, for example, fenofibrate, showed no benefit. What about the antihypertensive agents? In Camelot study, amlodipine showed slight benefits as regard plaque progression, reduction in plaque progression. Olmesartan showed slight benefit as regard the reduction in plaque progression in Oliver's trial. All other antihypertensive failed to show benefit. Perindopril, Ramppril, Aliskiren in those trials showed no benefit as regard the plaque progression reduction. Other agents studied, like the anticoagulants, no clear benefit, mixed data. Oral hypoglycemic agents, mixed data, the net is no clear benefit. Celestazole and others, no clear benefit. LDL apheresis showed no great benefit as regard long-term atheroma reduction. CETPI illustrate trial showed significant total atheroma volume reduction only total atheroma volume, but no outcome benefit, so it is not used. Let's come to the most 2 important items before I do finish. Statins. And we ask 3 questions to ourselves. Statin versus placebo trials and observational cohorts, it showed benefit. High versus low intensity statin trials, also high statins, intensity statins showed more benefit. And statin trials and the plaque composition itself, what is there? As early as 2004, we all remember the comparison between paravastatin and the atorvastatin by that era, and then showed significance in lipid lowering, as a lipid lowering therapy in regression of atherosclerotic plaque. Paravastatin did not show this. He tried also to compare between molecules within the same class, rosuvastatin versus atorvastatin, in a recent study for coronary plaque stabilization. Of course, rosuvastatin is more potent as regard the numeric reduction, okay? But when we went to the fibrous cap, this study showed that rosuvastatin showed more thickening of the virus of the fibrous cap more than the atorvastatin, significantly after 1 month. Significance reached after 12 months, 1 year. Showed also that with the OCT, as I mentioned in the investigations, that it is the gold standard as regard the thickness, measuring the thickness of the cap. rosuvastatin showed benefit and more significance than atorvastatin, and they concluded that in similar reductions of lipid profile, rosuvastatin showed more rapid and robust plaque stabilization and regression of plaque volume. There is some sort of paradox as regards the statin. Statins and the coronary plaque calcium. We all know that when we see calcium, we know that there is something nasty there. And if the patient is going to have cardiac catheterization, we are afraid of a lot of complications. But as regards being a lot of calcium deposition, as we see here in high intensity statin, this gives more stability for the plaque not to be fissured or ruptured. So we have some sort of paradox. When we put both the ezetimibe with the statin, we know all we know the precise IVAS trial when it showed that the use of most of atorvastatin and the rosuvastatin also, but here we are dealing with ezetimibe with atorvastatin, showed greater reduction in the plaque volume rather being the atorvastatin alone. It applies also for the rosuvastatin trials. So as a statin overview as regards the plaque, statins induce plaque regression in a dose-dependent manner proportionally to reductions in LDL cholesterol. الحقيقة البنفيتس اللي بتيجي للأثيروما significant when the LDL cholesterol is below 50 in most of the trials. IVAS is the main modality, but coronary CT in the last few years had some position. In response to statin, what happens? Fibrous, calcified plaque volumes appear to increase, whereas non-calcified, fibrofatty, necrotic core volume decrease. What about PCSK9, the other one after statin? Also, as early as 2016, there was a study named or called Glagov study using evolocumab, and it showed that evolocumab showed significant regression when added to statin in comparison to statin monotherapy, regression of atherosclerotic plaque. But Odyssey J-IVAS showed some sort of paradox despite the robust results came from liricumab for the cardiovascular outcome reduction. It showed no significant reduction in atheroma parameters. So this derived the ACC 22. This is only 4 months ago, when Lawrence Raber in Bern, Switzerland, with his colleagues, put a very, very elegant and very smart design for trial to judge the PCSK9 inhibitor and atheroma volume. They put a primary endpoint as regard the percentage of atheroma volume, secondary to see the core, secondary endpoints, see the core and lipid core, and to see the fibrous cap thickness. Why I'm saying it is smart? Because they put two arms, okay, those with acute myocardial infarction, whether non-STEMI or STEMI, undergoing coronary angiography, successful PCI of the infarct vessel, وشافوا two non-infarct related arteries at least with angiographic evidence of atherosclerosis. يعني لقوا في الناس اللي عملوا لهم PCI عندنا 2 or more non-infarct related arteries من 20 ل 50% stenotic burden. ادوا نو ستاتين LDL اكتر من 125 ولو اون ستاتين لو اكتر من 70. المهم الانرولمنت ده البيز لاين كان لطيف قوي لان هم بصوا بالايفس والانفراريد سبكتروسكوبي وبالاو سي تي، واضافوا بعد كده اليروكيوماب او بلاسيبو للريزوفاستاتين 20 على الناحيتين، واعادوا بعد 1 year 52 weeks the study again with IVUS, NIRS and OCT. The primary endpoint was met. Change in percent atheroma volume with IVUS was significant in favor of alirocumab. And as regard the infrared modality, the maximum lipid core dropped with alirocumab significantly rather than the placebo. As regard the minimum fibrous cap thickening using OCT, it also showed significant thickness or significant increase in thickness as regard the alirocumab. This was hand in hand with LDL reduction. So they concluded that alirocumab therapy resulted in greater decrease in percentage atheroma volume, larger reduction in lipid burden, and the higher increase in minimal fibrous cap thickening. والحقيقة rationale in favor of early initiation of very intensive LDL lowering in the setting of acute MI. This gives us explanation for the rationale and the trials that enhanced giving PCSK9 inhibitors or target strategic PCSK9 inhibition for those with acute setting. My last two slides, and early in 2022, a few weeks ago, Jack published a state-of-art review as regard the coronary atherosclerotic plaque regression. حقيقة أنصح حضراتكم جميعا تقروها لأن هي عاملة اوفر فيو رائع للقصة، يعني ستيت اوف ذا ارت فعلا، والحقيقة بقى له أسابيع. والحقيقة أنا أخذت منه one slide to be my last slide and my take home message slide. Here is the coronary atherosclerotic plaque regression. الشكل ده بيلخص الفلسفي والاستراتيجي والتاكتكس اللي ممكن نفكر فيها. الايمجنج بلاك في انفيزيف ونون انفيزيف. انفيزيف شرحنا ان الجولد ستاندرد فور بلاك كوانتيفيكيشن كان اسيس مورفولوجي اند بوست بروسيسنج with post processing، وده بيعتمد طبعا الى حد ما برضه الاوبريتور يكون مصحصح معانا شويه او التكنيشن. الاو سي تي higher resolution allows visualization of thin cap fibroatheroma and the lipid content، لكن الحقيقه ما بيقدرش يجيب لي التوتال ليبيد كونتنت لان البنتريشن باور بتاعه اقل كتير من الايفس. والسيمي كوانتيتيف ليبيد ميجرمنت بالانفراريد سبكتروجرافي. لو بصينا للنون انفيزيف بنتكلم على السي تي that can measure الفوليوم and characterize plaque، assess الهاي ريسك فيتشرز زي ما شرحناهم، وجود كورليشن with ايفس. لو انا عامل سي تي المريض ودخلت وانا بحط له دعامات ومحتاج ابص بالايفس، الحقيقه هيكون عندي البيست كومبينيشن من انفيزيف ونون انفيزيف. البيت والام ار اي لسه في طور البروجريس وما قدمولناش حاجات كتيره. يمكن الام ار اي في البلاك بتاعه الكاروتيك ايمجنج قدمت بعض البروجريس. از ريجارد الاستراتيجيز اللي هي الكور بتاع محاضرتنا النهارده، ستاتنز الحقيقه مكانها محفوظ، والبي سي اس كي 9. يعني لو حاولنا اننا ننتقي 2 أو 3 من الكولشيسين والاي بي اي والنون فارماكولوجيك والستاتين وبي سي اس كي 9 سي تي بي ازيتيمايب، حقيقه ده ماتشنج الايرا الجديده او الاسامبشن الجديد ان العين لو فيري هاي ريسك او الاكستريم ريسك انا ببدا بستاتين وازيتيمايب وبي سي اس كي 9 انهبيتورز. والحقيقه هم اكتر ناس زي ما حضراتكم شفتوا قدموا لنا outcome as regard البلاك فوليوم ريجريشن. ايه البوتنشال فيوتشر ابلكيشنز؟ further outcome and therapeutic trials، وده التحدي الكبير لان احنا مش قادرين نعمل ديزاين معين يقول لنا انا لما اقلل البلاك ريجريشن بالشكل الفلاني انا هاخد مورتاليتي بنفيت بالشكل الفلاني. هم بيحاولوا يضفروا دلوقتي السيرجت اند بوينت لهارد اند بوينت. الحقيقه اتس تو هارد، فيري هارد، ويمكن ناخد راي حضراتكم بعد ما نخلص التوك. الدايركت ايمجنج تو مونيتور تريتمنت ريسبونس ده حلم عندنا اننا to follow our patients. والبوبوليشن سكريننج في كويشن مارك مين اللي هعمل له سكريننج از ريجارد بلاك. اعتقد الثلاثه ايتمز اللي تحت دول واللي انا بختم بيهم دول هيكونوا الاريا اوف ديسكشن بعد ما اخلص. Thank you very much and I'm glad.
شكرا دكتور ياسر for your very illustrative and informative presentation. يمكن السلايد الأخيرة دكتور ياسر اللي حضرتك حضرتها من الحاجات اللي يمكن تعمل راب اب لكل المحاضرة. يمكن لو بصينا على النون فارماكولوجيكال هنجد ان ريكومنديشن موجود مع الاكسرسايز علشان يكون عندنا امبروفمنت في الاندوثيليال. عندنا رود ماب من الدراجز ان احنا معانا الهايدروستاتين وممكن نضيف الازيتامايب من البدايه اكوردنج للليفل او التارجت اللي احنا عايزين نوصل له، وهناخد جود امباكت على البلاك ريجريشن. والرول اوف الباسكناين تارجت ثيرابي هيكون ليه رول، او على الاقل الانهبيتور اللي موجوده بالافيدنس في الباسمان ترايل. ممكن كمان عندنا اوبشنالز لو العيان بتاعنا في الهاي ترايجليسرايد ليفل عالي، انا برضو هاخد من الاي بي اي اديشنال بنفيت على البلاك ريجريشن. الكولشيسين لسه مش قادرين ناخد ديسيجن ان هو نقدر نخليه كفيكسد دوز في موست بيشنتس اوف الام اي او لا، ولكنه بوتنشال. والجزء الثاني اللي هيبقى بقى اللي هو حضرتك حطيته في البوتنشال ابلكيشنز ان انا هاو تو مونيتور. انا مش معقول انا عيان عندي ميديكال ستيبل ما عنديش ايفنس وهدخل اعمل له ايفس او او سي تي او حاجه انفيزيف علشان اقدر امونيتور انه حصل بلاك ريجريشن ولا لا. فشايف حضرتك انه ممكن في الفيوتشر النون انفيزيف مع مور اكيورسي ومور ستاديز ومور ويل ديزايند ترايلز هيكون هو ده الميثود اللي نقدر من خلالها نحدد ان فعلا في بلاك ريجريشن، في بوزيتيف ريسبونس للانترفنشنز من الدراجز المتعدده اللي هنستخدمها ولا لا يا دكتور ياسر؟
اشكرك دكتور تامن طبعا على الراب اب اللي انت عملته. الحقيقه فعلا ده يعني كومنت مهم، واي ثينك كلنا ايمنج لتحسين النون انفيزيف ستاديز. يعني زي ما حضرتك قلت كده انا مش كل واحد ادخله اعمل له انفيزيف ستادي يعني لا كوست بنفيت ولا ايثيكال ولا فاحنا ايمنج للنون انفيزيف ستادي انه يتحسن از ريجارد سي تي والبيت والام ار اي. بس الحقيقه يمكن اللي واخد بروجريس في الوقت الاخير more and more progress الحقيقه الكوروناري سي تي والبوست بروسيسنج اكشنز اللي بتتعمل حسنت لنا كتير. يمكن انا في السلايدز اللي عرضتها كان في حاجه بتوري لنا البروجرس اللي حصل، وان ازاي لما بتبعت لحد فاهم شغله كويس از ريجارد. حضرتك معايا؟
انا معاك.
احنا معاك يا
الوفا، حد يقول الوفا. فانا كنت عامل شير للسلايد دي، يمكن هي دي ده المستقبل في رايي اللي قدامنا از ريجارد السي تي. ويمكن كمان البروجرس اللي في البيت، يمكن البيت بس عشان غالي مش موجود عندنا، وفي اللي يمكن الام ار اي بيتحرك برضه فورورد شويه، لكن البروجرس بتاع السي تي هو اللي واخد الابر هاند في اللاست فيو ييرز.
يعني anyway هو الليسنز من البلاك ريجريشن ستاديز انها most of the plaque regression is related mainly to aggressive lipid lowering.
بالظبط، لانه زي ما حضرتك بتقول كان تحت ال 50 ما بلاقيش السيجنيفيكانس اللي تحت 50 ال دي ال.
This is the lesson number one. Lesson number two, the question you asked about whether it is related to cardiovascular outcome or not.
انا مش سامعكم ليه يا جماعه؟
مش عارفين يا عاطف، والله حاجه عندك مشكله، احنا سامعين بعض كويس.
سيد ماسك نفسه عايز يضحك اهو بس مش قادر.
I feel يا دكتور ياسر بالنسبه للاوتكم وعلاقتها بالبلاك ريجريشن ان احنا we really don't need this to be proved because we know that the lower LDL cholesterol is the better regarding the outcome, and now we have evidence that this very low LDL cholesterol may have impact on plaque regressions. So the proof of plaque regression by itself is a proof of the lipid theory in whole whether it will reflected in outcome trial, because this need a very huge randomized trials وinvasive procedures.
Very complicated. والمالتي فاريت اللي موجود مش هيسمح بسهوله بقصه زي كده.
So any other comments of my colleagues?
يس دكتور اشرف، انا مش عارف انتوا سامعيني ولا لا؟
سامعينك يا عاطف.
كده سامعينك.
دكتور عاطف اخرج وخش تاني، اخرج خالص، ليف ذا ويبينار وخش تاني. اخرج وخش تاني.
بس احنا سامعينك وشايفينك كويس يا جماعه.
طيب دكتور ياسر، امتى تريكومند اليوز اوف الكولشيسين، وايه ريكومنديشن از يوز كانتي انفلاماتوري كرول من الدراجز اللي بتقلل البلاك ريجريشن؟ يعني واتس يور ريكومنديشن فور بريسكرايبنج الكولشيسين في العيان الاكيوت كوروناري سندروم، في عيان المايوكارديال انفاركشن، في العيان اللي دخل برايمري بي سي اي او ال انفيزيف؟ ريكومنديشن ايه لليوز اوف كولشيسين؟
Please share screen سيد while we are discussing.
الحقيقه احنا ما عندناش طبعا حاجه واضحه كلير ريكومنديشن امتى، بس از ريجارد لو بنتكلم ككونسنسس، العيان اللي عنده كرونيك انفلاماتوري ستيت هو اكتر حد يستفيد من الكولشيسين وات ايفر بقى، لان حتى الايرا بتاعت الكرونيك انفلاماتوري بدات تظهر حتى في الجايد لاينز بتاعتنا في اكتر من جايد لاينز. فاي بليف ان لو حد عنده كرونيك انفلاماتوري ستيت he will benefit much from colchicine. other than this لا، ما عنديش حاجه سوليد ان انا اقدر اديه بريكومنديشن صريحه من جايد لاينز بهاي ريكومنديشن بوست اكيوت كوروناري سندروم.
You have any comment, Atif?
Yes, Dr. Yasser, thank you very much. It's good to know that atherosclerotic plaque regression can be done by medical treatment we have in our hand. And you speak about the secondary prevention or even the primary prevention. There is a large study called the PISA study for 4,000 patients who have no risk factor and they have low and they have normal LDL cholesterol can be between 70 or 60, and they found that the atherosclerotic plaque starts unexpectedly at this normal level, not over 50. Therefore, they direct us to the primordial prevention of the prevention of atherosclerosis from young ages in order to prevent the plaque progression. Because I don't know if I make a plaque progression in secondary prevention after the event, it will happen in other site. But if we start early using these drugs from 11 years, if we detect this patient that they have the plaque progression, which can have an event in the 20s or the 30s, I think the primordial prevention can be preceded by our practice. What do you think about that? The PISA study is published in the JAC 2017. It is stated it is the progression of early subclinical atherosclerosis.
You're absolutely right, Dr. Atif. You're absolutely right. لأن the primary prevention is the great challenge all over the time. You will gain much from the secondary prevention, of course, but the challenge is for the primary prevention. But how would we go for this? It needs some arrangement. How would we tackle, how would we screen, to whom we screen, the budget of screening, etc. I think it's very important, but it's challenging as regard the logistics and the design.
Dr. Ashraf, if we take a sample for the LDL and we find it, for example, 100 or 120, and we multiply it by the age, we can detect the threshold of the progression of the atheroma.
Okay, till now, as you know, Atif, we are depending on risk assessment and risk scoring system, and there is new genetic risk scoring system. So, except if the patient is known to have familial hypercholesterolemia or there is possibility of familial hypercholesterolemia, I think we're still depending on the risk score to start early statin therapy in those high-risk patients to try to prevent progression of the atherosclerotic plaque. I think because of strict of time, we can allow me, Atif, to proceed. I'd like to, in this occasion, to thank Amgen for the support of our CME activity, IAVA CardioRisk Waves. So Professor Said Farag will talk to us about the role of Evomab in recent MI patients and acute settings. Professor Said.
هو بس الدكتور سيد يعني هيبدا المحاضره عشان هيحتفل بالدوري، عندهم ماتش يحتفل بالدوري، فيعني
ماشي
يدي محاضره ويحتفل بالدوري، حد قده؟
يا عم لا دوري ولا حاجه، لسه بدري، هتلعبوا بالناشئين والدنيا هتبقى زي كويسه. انا مش عارف السكرين شيرد. We have the screen shared,
but so we want it to be in a slideshow pattern.
Okay.
Yeah, it's okay. It's okay.
Okay. Thank you, Professor Ashraf, for this kind introduction. And also, I'd like to thank the IAVA board for sharing in such an elegant IAVA night as usual for the CME activities. And I'd like also to thank the Amgen company for their support for the CMEs of IAVA. It is tremendous and continuous. Thank you very much. And I have today my presentation about one of their emerging innovations in treating the dyslipidemia. And I think we are lucky enough that we are now have a lot of studies, have a lot of researches, have a lot of data which give us a knowledge about the risk categorization of the patients and the magnitude of the problem. And also we have a lot of data which supporting the new innovations like BCSK9 inhibitors and BCSK9 targeted therapy. Also, as we mentioned before in several lectures, that the lower the better, but also again and again, the earlier the better. And there is a lot of data about that. And today we will discuss one of them, which is the role of evolocumab in recent MI patient and acute setting. And I think the subset of patients need really early interventions by those innovations to improve the outcome of our patients. My agenda today is about the ACS burden guidelines recommendation, and I think we have all to know the burden of the acute coronary syndrome and how the guidelines drive our management in such subsets of patients. Also, the Fourier sub-analysis for history of MI patients, who all know that the Fourier trial is one of the landmark trials which put the BCSK9 to the stage in the guidelines. Fourier sub-analysis also for recent MI patients, which raised the flag for the early intervention for the dyslipidemic patient with acute coronary syndrome. And lastly, also the EVOPAX, which is a study for the acute coronary syndrome, which is also aiming the early intervention for those patients. As I mentioned before, the magnitude of the problem we have to know, because by knowing the magnitude of the problem, we are get all the efforts, all the weapons we have on our hands to use to counteract those major figures that you see in the screen. Acute coronary syndrome is a common and results in significant morbidity and mortality globally. If we look out to the incidence and prevalence, every 40 seconds a person will have an MI, imagine, and 7 million total global annual estimate of acute MI, which is also a very big number. 32 million MIs and strokes occur worldwide every year, another very, very big number. And 605,000 estimated annual incidence of new MIs in the US, 200,000 estimated annual incidence of recurrent MIs in the US, with a 14% of patients who experience an MI will die as a result of those MI. $18 million deaths worldwide from the cardiovascular deaths are due to MI and stroke. So a very big percentage for deaths due to MI. Was 45 years, about 23%. For those from 45 to 65, about 10%. And from 65 to 75, about 22. And above 75 is about 31% mortality rate. It is not also those data, but another bleak data about the patient with ACS have significant economic burden, which is based upon those very bleak health burdens. The main patients and caregiver, do you hear me?
Okay, Said, go ahead.
Okay. Patients with ECS have significant loss of productivity and indirect cost the year after the cardiovascular event. And this is a lost productive time and indirect cost are important component of the economic burden imposed on the society of acute coronary syndrome. And if you have a look here in this slide, the caregiver loss is about 16%. The presentism, impaired performance at work is about 9%. Patient absenteeism about 25%, and patient absenteeism due to index hospitalization and sick leave about 51%. This means cost. So it is not only the healthcare burden, but also the economic burden for the caregiver annual work loss in ECS. High unmet need in post-MI patients, which is another important issue. In 5, patients with MI are rehospitalized within 30 days, with a mean length of stay of patients with MI for 5.4 days. And also 18% readmitted with a cardiovascular event, MI, revascularization, unstable, stroke within the 1 year post-discharge, which is another high percentage of patients. About 30% higher relative risk for all-cause death and cardiovascular outcome after MI. Again, I'd like here to confirm the increased costs after MI, and the costs include medical, inpatient, emergency room, ambulatory, office visit, outpatient visit, other medical and pharmaceuticals. It is calculated in the US that post-MI cost in the US for 1 year, it is $52,000. Why here the cost calculation is important? Because we are dealing now with the innovations of drugs, of molecules, that it is very costly. But how about the cost effectiveness in relation to the cost spent for those patients who are dealt medically in hospitals, in outpatients, interventions, and surgery? The current cardiovascular events are more severe and costly compared with the first event. If we have a look here that the 7-year survival in 30-day survivors of MI in UK, from survivors of the first MI, 63%, and this percentage is coming deep down with a 40% minus in survivors of recurrent MIs. So you can appreciate here the difference of survivors for after the first MI and after the recurrent MIs at the 7-year. Again, the total cost for both cardiovascular event from the acute coronary syndrome in UK, that the acute cost, it is significantly elevated if the patient is subjected to recurrent MI rather than the first MI. And here is also the nearly 1 in 5 post-MI patients will have a recurrent event during the first year and the continued increased risk beyond the first year. So we still have the risk beyond the occurrence of the risk after the first year, which is also very important to mention in this observational retrospective cohort study from the Swedish National Registries of all patients with a prior MI. And we can appreciate here that the 4 patients without a combined endpoint during the first year, the composite antibiotic risk remained high at nearly 20% in the following 30 months, which is very high percentage. One of the strongest predictors, as you can appreciate here, of the future ischemic events is the prior history of the cardiovascular events. So far, there's a prior history of cardiovascular events like MIs, like stroke, rehospitalizations for acute coronary syndrome. So far, you have those. So far, the risk is higher, and those are very important predictors for future ischemic events. That's why the guidelines came up to the stage with a clear recommendation with a level 1, class 1 level of A recommendation that in secondary prevention for patients at very high risk and LDL reduction more than 50% from baseline and an LDL goal of less than 55 are recommended for secondary prevention, 55 rule. And again here, which is very important, and I think this recommendation was a step up in the coming guidelines from 2B to up for those patients with associated cardiovascular disease who experience a second vascular event within 2 years. Those patients, while taking maximum tolerated statin-based therapy, the target will be much more lower, to be less than 40. And it is very reasonable because those patients who are subjected to another attack, despite their maximally tolerated statin therapy within 2 years, they are deserving to get the target much more lower, down to 40. And I think, as I mentioned, this will be step up in the coming guidelines. Also, which is very important, an important difference between 2016 and 2019 for the more intensive and aggressive lipid-lowering therapy, because for those patients with secondary prevention and very high risk not achieving their target with maximum tolerated statin dose and ezetimibe, we have immediately to combine them with PCSK9 inhibitor. This is a class 1 recommendation. What's much more important in the guidelines in 2019 also, that we are not adding the PCSK9 to the maximum tolerated dose and ezetimibe, but also we have to be careful to add it as early as we can, maybe at the index hospitalization of ACS if they are not at the target during this attack. So we have, despite the maximum tolerated dose of a statin and ezetimibe, we have immediately during hospitalization to add the PCSK9, which again raises the flag of the earlier the better, and especially in those patients with very high risk ACS. As I mentioned before, the Fourier trial, which one of the landmark trials, changed the stage of the management of the dyslipidemia, and those patients, especially with very high risk not achieving the target, evolocumab in cardiovascular disease, evolocumab outcome trial, evolocumab and the clinical outcome in patients with cardiovascular disease. Here is the randomization, 1-to-1 randomization for those patients aged from 40 to 85, MI, stroke, or peripheral arterial disease, additional risk factor 1 major or 2 minor, optimal background lipid therapy, including effective dose of the statin plus or minus ezetimibe with LDL cholesterol more or equal to 70 or non-HDL cholesterol more or equal to 100. For those patients, randomization 1-to-1 evolocumab subcutaneous for 140 twice weekly or twice every 2 weeks or 420 milligram monthly. This randomized to placebo with the same doses. If we have a look here for the endpoint, the primary endpoint was composite of cardiovascular death, MI, stroke, hospitalization for unstable angina or coronary vascularization. And the key secondary here is the composite of cardiovascular death, MI, or stroke. And of course, the other secondary death, cardiovascular death, MI, stroke, coronary vascularization, cardiovascular death or hospitalization for heart failure, ischemic stroke, or transient ischemic attack. If you have a look here to the primary and secondary endpoints, we are now can appreciate the potency of this and the power of this study for aiming those very fatal primary and secondary endpoints. The median LDL levels over time for all patients, we can appreciate here that the LLDL cholesterol was significantly reduced in evolocumab group with a median of 30 milligram per deciliter, including 42% who achieved level less than 25, which is a very considerable and very big percentage for reduction to a level down to 25 versus 0.1% only, of course, in the placebo group. As a composite of cardiovascular death, MI, and stroke, hospitalization for unstable angina or coronary vascularization, and again here coronary vascularization means cost, hospitalization means cost, and all of them means healthcare burden. We can appreciate here that the 15% relative risk reduction between evolocumab and the placebo. For the key secondary endpoints, we can appreciate here also that with evolocumab group, the 20% relative risk reduction for the key secondary endpoints, including composite cardiovascular death, MI, or stroke. The clinical benefits of evolocumab in patients with a history of MI. This is an analysis from Fourier for those patients with very high risk who are subjected, not established coronary artery disease only, but also subjected to MI, which means, yes, they are very high risk, but their history of MI put them in a more risk, and which give them the chance to be dealt with more intensive lipid-lowering therapy. Patients at higher cardiovascular risk may derive greater benefit from PCSK9 inhibitor. Again, the greater the risk, the greater the benefit when using the new innovation, the new intervention with the PCSK9 inhibition. Within the broad subgroup of patients with prior MI in Fourier, this group of MI, they investigated if readily ascertain clinical features of cardiac history identified patients like at higher cardiovascular risk who derive the greater benefit from PCSK9 inhibition. Actually, here it is analysis redirected to about 22,000 patients with prior MI divided into two subgroups on basis of 3 factors. Time from qualifying MI, which is very important, and also the presence of residual multivessel disease at the baseline. This is another issue. Outcome of interest: cardiovascular death, MI or stroke. Analysis: risk of cardiovascular events in placebo arm in patient with or without specific high-risk features, and the efficacy of evolocumab versus placebo within each subgroup. And let's have a look now to the curves for those patients. And we can appreciate here for the two groups, patients qualifying MI less than 2 years ago, they have a relative risk reduction for the cardiovascular death, MI or stroke by 24%. For those patients, MI more than 2 years, they have 13% relative risk reduction. And if you have a deep lock to those two percentages, this again gave the impact on the flag which raised that the earlier the better. Again, for those patients with MI less than 2 years, the risk reduction was much more for 24 versus 13 for those MI more than 2 years. For those patients with 2 prior MIs versus 1 prior MI, for those patients with 2 prior MIs, 21% relative risk reduction for CV death, MI, and stroke versus 16 relative risk reduction in 1 prior MI. And this is another impact on another flag, which is the greater the risk, which is here by the 2 prior MIs, the more the benefits for relative risk reduction, as you can appreciate in this slide. Also, again here, for those patients with multivessel disease versus no multivessel disease, for those patients with multivessel disease, which is actually estimated as extreme high risk, there is 30% relative risk reduction versus 11 relative risk reduction. So from this sub-analysis for this 4-year trial, we can here see that the earlier the better for those patients, and also here, the greater the risk, the greater the benefit. The patient closer to their most recent MI with multiple prior MIs with multivessel disease are at from 34 to 90% risk for major vascular events. You can appreciate here how the risk is great. The patients experience substantial relative risk reduction for about 30%, absolute risk reduction for about 4.4% over 3 years with the new title, which is the lowering therapy with PCSK9 inhibitors like evolocumab. Evolocumab and cardiovascular outcome in patients with recent myocardial infarction. And this is another sub-analysis from the 4-year trial. From the baseline characteristics, the median time from MI per month is recent MI is about 4.5 months. And we can appreciate here that the 3-year event rate in recent versus remote MI, it is here for this incidence of primary endpoint. We can appreciate here that the 3-year Kaplan-Meier event rate is much more higher with those with recent MI. For incidence of key secondary endpoint, again, here also we can appreciate that the key secondary endpoint is higher for those patients with recent MI versus remote MI. What is the impact of evolocumab on both groups of patients? For recent MI, we have 19 relative risk reduction. For those patients with remote MI, we have 8% relative risk reduction. And this is again has an impact on the flag which raised for the earlier, the better. For those patients with recent MI, much more better than those patients with remote MI. To start earlier as we can. Reduction of the key secondary endpoint cardiovascular disease, MI, and stroke with evolocumab in 25% relative risk reduction for recent MI versus 15% relative risk reduction for those patients with remote MI. The summary here, the patient with recent MI were at higher risk of major adverse cardiovascular events compared with those with a remote MI. And that's why in recent MI patient, evolocumab reduced the risk of primary endpoints by 19% with a number needed to treat, which is very considerable, 27 over 3 years. The risk of cardiovascular death, MI, or stroke was reduced by 25%, and again was a number needed to treat of 32 over 3 years. What have the PCSK9 inhibitor studies in ACS shown? This is a very recent study, which is the evolocumab for early reduction of LDL cholesterol levels in patients with acute coronary syndrome, with a primary objective, evaluate the effectiveness of evolocumab versus placebo in LDL reduction in acute phase of acute coronary syndrome after 8 weeks. And I think this is one of the most recent studies for addressing the importance of using the PCSK9 inhibitor evolocumab to in those patients with acute coronary syndrome. Was also a secondary objectives of to assess safety and tolerability of evolocumab administration in acute phase of ACS, with exploratory objectives to assess the effect of evolocumab versus placebo on inflammatory markers like high sensitive C-reactive protein, platelet function, occurrence of contrast-induced acute kidney injury, incidence of centrally adjudicated cardiovascular event, and also the lipid core burden index. If we have a look here to the randomization of those patients randomized in hospital in hospital admission for 72 hours with placebo, subcutaneous plus atorvastatin, evolocumab 420 plus atorvastatin 40 milligram with a follow-up at week 8. And we can appreciate here that in EVOBAC's primary endpoint showed significant reduction in LDL cholesterol at 8 weeks. And also in EVOBAC's 90% of evolocumab patients achieved ECS and ES, of course, LDL guideline goal of 55. It's very important. It's very high percentage for achieving the target in such a very high risk and maybe also extreme risk patients if they have a multivessel disease with 90% achievement of the goal. And this is, I think, one of the important studies that give us the support to intervene early with the PCSK9 for those patients. And we can appreciate here also there is no new safety findings as regard any adverse events, serious adverse events, and adverse events resulting in study drug discontinuation. The p-value is almost non-significant. What is the effect of evolocumab on plaque vulnerability and rupture? And this is also, as Professor Yasser in his presentation raised up in the wrap-up slide, the last slide, it's very important to assess the plaque vulnerability, the plaque regression, using the new investigation modalities like the IVUS, that is not actually new, OCT, near spectroscopy, and also the CT, the MRI. Those are all important in assessing the plaque vulnerability and the plaque regression. This is called the Hugin, and the rationale of Hugin is to addition of evolocumab to optimize statin therapy will reduce the LDL cholesterol and therefore the lipid core, leading to a greater increase in the fibrin cap thickness, which is very important, as you know, in the vulnerability of the plaque, the lipid core and the lipid core, lipid arc, and the fibrous cap thickness. Here we have a look to the randomization. Patient randomized to placebo, subcutaneous monthly, evolocumab 420 also monthly, with the end of the study OCT IVUS to assess the vulnerability. And here we can appreciate that the minimum fibrous cap thickness for those patients on statins and the statins plus evolocumab, we can see here that the thickness actually increased in those patients with intensified lipid-lowering therapy, including PCSK9. And also here for the exploratory endpoints, patient percentage on treatment with minimum fibrin cap thickness less than 65, we can appreciate here this is much more lower percentage for those patients at intensive lipid-lowering therapy using evolocumab PCSK9 versus statin 30, statin evolocumab about 13% for those patients with the plaques with a fibrous cap thickness less than 65, which is the dangerous plaques or the vulnerable plaques. The Hugin study also here, if we have a lot, this corresponds to the reduction of LDL cholesterol from 140 to 28, which is 80% with evolocumab versus 140 to 87 for those on statin alone. You can appreciate here, of course, the intensive reduction of LDL cholesterol with the intensive lipid-lowering therapy. and as a linear relationship between achieved LDL cholesterol and the change in the minimum fibrous cap thickness of LDL levels ranging from 110 milligrams to as low as 20. We can appreciate here in this graph that with 20, of course, we have a higher fibrous cap thickness rather than the 100 milligram per deciliter LDL. As a summary of my presentation, my dear professors and colleagues, the 4-year trial, which is I mentioned before, one of the landmark trials for using those innovation and inhibitions, with Repassa significantly and safely the major cardiovascular event added to therapy in recent MI patients. It's very important substitute patients. They are very high risk patients. Evolocumab reduced the risk of the primary endpoint by 19% of number needed to treat 27 over 3 years. The risk of cardiovascular MI stroke was reduced also by 25% with number needed to 32 over 3 years. And according to the new ECC guidelines for secondary prevention, patient at very high risk not achieving the new target LDL on maximum tolerated dose of statin is mandatory with +1 level of evidence A recommendation those patients to add PCSK9. For patients who present with an ECS and not achieving their target LDL on maximum tolerated dose of a statin and ezetimibe, adding PCSK9 inhibitor as early as we can after the event, if possible during the hospitalization, even during the hospitalization of the ACS event. And finally, it's not only the matter of the LDL, it's not only the matter of the earlier to start, it is also the matter of the vessel and the plaques. The gene study proved that achieving lower LDL levels has been associated with a smaller lipid arc, increased fibrous cap thickness, and a lower percentage of vulnerable plaques and plaque rupture. So fortunately, we are very lucky to now have estimation of the risk of the patient, and now we have the innovations to manage those estimated risk of the patients, and thank you for that. I finished.
Okay, thank you, Sayed. Actually, the PCSK9 inhibitor is not yet anymore just an emerging therapy. It is now a well-established part of the therapy of lipid lowering, especially in high risk, especially in patient post-acute care syndrome. Even now, many patients in the intensive care with acute events could start triple therapy, including PCSK9 inhibitor in the intensive care, not waiting for the results of or the effect of high-intensity combination lipid lowering oral therapy, especially those with extreme risk, with recurrent acute coronary syndrome, with multi-vessel coronary artery disease, with heterozygous familial hypercholesterolemia and premature atherosclerosis. So it's now a well-established part of therapy. One should think in many situations when he finds the LDL goal is not at goal, please don't hesitate to start PCSK9 inhibitors to decrease the cardiovascular events and improve the cardiovascular outcome. If any other questions or comments, Dr. Alaa, تفضل.
Thank you, Professor Said. It's an elegant as usual. I said that I enjoyed so much, and your message is clear about the use of PCSK9 inhibitor, Evolocumab, because the number needed treatments of the post-myocardial infarction is very important message. If you deliver the molecule inside the venue, inside the hospital, or even post-myocardial infarction or post-PCI, I think if the patient advised to take this molecule inside the hospital, I think it's very important to deliver and to continue and to improve the adherence, as I saw. So what do you think about if we advise this and addressing this message to introduce the molecule inside the venue, inside the hospital?
Yes. It's very important, as you mentioned, Professor Alaa, to start as early as we can. And this is very clear from the EVOBAX trial that the data is very supporting to us to start. because of also the healthcare burden for those patients, and again for the economic burden for subjecting them to more interventions and more hospital stays and recurrent attacks.
Thank you very much.
Okay. If there is no other, Yasser, you want to say something? Unmute, please unmute, Yasser.
سوري، كنت احب اسال بس دكتور السيد، احنا عندنا cumulative data as regard the primary و secondary في البي سي اس كي 9 inhibitors. What about the targeted therapy؟ يعني احنا دلوقتي على انكليسيران، لغايه ما هناخد outcome benefit it will take time. نوظف ده فين وده فين دلوقتي في رايك؟
يعني if I understand you well, we have what's called now the BCSK9 targeted therapy. Either using the BCSK9 inhibitor, either using the small interfering RNA. It depends upon the availability, the feasibility, the financial support of that or of one of them. Yes, we have a lower percentage of reduction of LDL cholesterol with PCSK9 inhibitor, which is approaching 60%. Another important issue for PCSK9 inhibitor in comparison to the inclisiran is that they are now dive into the vessel with IVUS and OCT like Hugin trials, and they are proving the regression of the plaque, the stabilization of the plaque. And this is, I think, one of the important supportive data for the BCSK9 targeted therapy, which gives some privileges to BCSK9 inhibitor versus
of course, both of them, Dr. Yasser, PCSK9 inhibitor or inclisiran, can be used interchangeably in the same clinical situations. However, we have more evidence regarding PCSK9 inhibitor monoclonal antibodies till now, but the guidelines put them together in all together. Maybe the main advantage of PCSK9 monoclonal antibody that if you give inclisiran for 6 months in such patients, you will wait for the 6 months to know the effect, and you will not able to change or adjust the dose or change to PCSK9 inhibitor monoclonal, for example, to achieve more effect if you are not at goal. However, the PCSK9 inhibitors can be assessed every 2 or 3, 4 weeks, can be increase the dose regarding alirocumab, or even if patient are not responsive, you can change it to inclisiran. Okay, so I think we can conclude these fantastic sessions. It covered very interesting subjects from screening of familial hypercholesterolemia, lipoprotein little a, plaque regressions, and lastly, the effect of Repatha in acute coronary syndrome and post-acute myocardial infarction. I would like to thank you all, Atif, Sayed, Tamer, Atman, Abindari. Thank you, Alcom, and thank Amgens, and see you maybe in Cardio Go, inshallah.
Thank you very much.
Assalamu alaikum.